one of which is radioembolization. The other is actually a systemic therapy for lymphoma, Zevalin. And it has properties that allow for both imaging and therapy. So it emits beta radiation to destroy tissues it's surrounded by, at about 3 millimeters mean tissue penetration. And it also emits photons during decay, which we can ultimately detect for imaging purposes, which is very useful, obviously. So actually, Y90 was first described shockingly a long time ago in the 60s, where it was administered from the celiac artery for liver disease, pancreatic mets specifically. And that's followed by subsequent studies where they kind of did the same thing for neuroendocrine tumors. They did realize, though, that administering from the celiac is fraught with problems, because obviously you get a good amount of gastric radiation, and so subsequently the procedure was changed. But throughout the studies in the 60s and 70s, they did find out that there was an objective decrease in tumor size for most of these patients, regardless of the toxicity, which was secondary to not really knowing how to deliver the dose. They did some research in the 80s on how large the embospheres were supposed to be, and found out that you really have to have microspheres between 15 and 30 microns to lodge them in the hepatic tumors, rather than normal liver parenchyma. If you increase that size beyond 30, 40, 50 microns, you see that you get a lot of activity distributed throughout both the tumor and the normal parenchyma, which you really don't want. So there was a lot more progress made in the 80s and 90s with phase 1 clinical trials for both types of microspheres, which we'll talk about. That ultimately led to a humanitarian device exemption for the use of Y90 in hepatocellular carcinoma in 1999, which basically means that the FDA has kind of fast-tracked the therapy and allowed it to be used without maybe as much data as they would prefer, but there's clearly a benefit. One type of Y90, the resin type, which we'll talk about in a second, was FDA approved in 2002 for treatment of colorectal cancer metastases to the liver. In 2004, a study was published in JVIR by the Northwestern group, where Y90 was used for unresectable HCC in patients with portal vein thrombosis. And they had 15 patients with portal vein thrombosis that they administered Y90 to, and found that it was generally very well tolerated. There wasn't a substantial amount of liver toxicity. Nobody went into liver failure. And they found that the treatment resulted in a substantial amount of response for these patients. So what are the types of Y90 that people are using? Well, I'm going to hop around from the data for a second, so we can get a little more into what exactly Y90 is composed of, and the different flavors. Currently on the market, globally, there are two types, glass and resin. when I was a trainee, I always found it very difficult to keep them straight, and I didn't know why everything in medicine had to have two names. But resin is going to be your spheres, and the glass is going to be the Therasphere. Those are obviously the commercial names. But there's really no other competitors at this point currently on the market in terms of Y90. So I will tend to call them just Therasphere or Cerasphere, because there are no other iterations of glass or resin. But you can see here that although their sizes are approximately the same, the activity per bead is substantially higher for glass, right? It's quite a bit higher. And the number of particles per any given amount of activity is much higher for resin. So you are getting a huge number of particles compared to the glass in each vial. And that, as a result, will give you more embolic effects than you would see with glass. And so it's more akin to using like a bland embolic to some degree in terms of how it behaves. So with the resin, with the Certec, you will reach stasis and then start to reflux. Whereas with Therasphere, it's really not very easy to do that at all. It's actually quite difficult to ever do that. You have to be in like the smallest branch, to actually get reflux and an embolic effect. Throughout the development of Y90, it's evolved. The therapies evolved from what we had described before, where you're injecting it from the celiac into the whole liver, to subsequent studies demonstrating that really maybe we shouldn't be doing that. We should be targeting it to a specific lobe. And that has continued to evolve with current practice patterns favoring, for most patients with hepatocellular carcinoma at least, segmental or direct intratumoral infusion rather than treating normal surrounding liver. That you can see here with some case examples of a lobar dose, which has really hit the whole left lobe, versus a segmental dose, which is isolated and injected directly into the affected segment where the lesion is, but really spares the rest of the right lobe, to a very, very focal delivery that is practically, maybe even only, treating the tumor and maybe 1, 2, 3, 4 millimeters around the tumor. You can call that kind of like a subsegmentectomy, although I don't think that's defined in the literature, but it is certainly something that people are doing currently. Talk a little bit about the workup, and really Y90 is currently used in the liver for hepatocellular carcinoma very frequently, but also metastatic disease. The workups are very similar. We generally, at large, institutions in the US, have a disciplinary team which is involved in patient care that really directs the most appropriate therapy, since treatments are getting relatively complicated in terms of what people are candidates for, what they're not candidates for. Their treatment options have expanded. So it's very important to get multiple stakeholders involved, giving their opinions on what's best for the patient. Staging is going to be important, and we'll talk about HCC staging quite a bit. And then contrast enhanced sectional imaging, if available, is really your imaging tool of choice. Particularly MRI is what we like to try to use with hepatocellular carcinoma. whenever possible. And obviously with metastatic disease, PET-CT is going to be much more frequently encountered. The biggest labs that we look for, and these are, I would say, the most important ones for all local regional therapies. If you guys have had lectures on ablation or chemoembolization, really people should be hammering home the bilirubin and the albumin, because those give you the best global kind of bird's eye view of liver function. Obviously, you can use a number of other markers, and people have created pretty complex algorithms, but really it's, to make things simple, we tend to look at the bilirubin and albumin as those markers for how good the liver function is, how much can we treat, how much normal liver can we treat, how much normal liver should we avoid treating. So after the initial decision to proceed with Y90, patients will receive a mapping procedure. Then the planning and ordering of the dose is performed, then treatment, and we'll talk about peri-procedural cares and post-procedural follow-up. So the mapping procedure is idiosyncratic to radioembolization. You don't really do this for chemoembolization. You don't really need the simulation run, if you will, for other local regional therapies. But because Y90 is relatively toxic and inadvertent delivery into an organ adjacent to the liver or outside the liver, activity in the lungs can be pretty catastrophic potentially. You really have to make sure that your delivery is going to be safe by effectively performing the procedure and then injecting the MAA, the macroaggregated albumin, as a surrogate for Y90 to assess, number one, the lung shunt fraction, to make sure that substantial number of particles are not passing through from the artery directly into the hepatic veins or directly in the portal veins via shunting in patients who have a lot of tumor burden. And then subsequently, those beads can go to the lung and cause radiation-induced lung injury. Now, there's no absolute shunt fraction that prohibits a Y90 delivery. We can talk about that. It's kind of a higher level discussion than the basics, but there's no hard and fast rules except for you try to avoid more than 30 gray lungs in any particular delivery. Usually we're way, way, way under that. And there is some controversy with regards to, well, does the lung shunt fraction actually predict if somebody gets radiation induced lung injury? And there's definitely a camp that says that it maybe does not. But we still kind of err on the side of caution. And obtain those numbers as are required. The location and type of extrahepatic arteries are identified. So this is a big component of the mapping study. We're trying to identify gastric, falciform, phrenic, gastroduodenal, supraduodenal arteries that might be issues for our delivery. Should we reflex into those? Or should we involve those artery distribution? That could certainly lead to predominantly, the much dreaded GI ulceration situation, which can be pretty uncomfortable for patients and take quite a while to resolve, because the radiation beads will ulcerate any GI mucosa that you deliver them into, to some degree. It really depends how much you inject, where you inject, etc. And then you're really trying to figure out the vascular tumor supply and identify what kind of Y90 are you going to use, how much of it do you need, what kind of activity do you need. So we'll do a little case just as an example. This is a patient that's 45 years old, has unfortunately metastatic breast cancer with a lesion in the left hepatic lobe. It's about 2.5 centimeters, 3 centimeters. This is our mapping angiography, and you can see that this is, an anatomic variant. We're injecting contrast into what looks like is the splenic trunk here, with spleen being here, and then we see a vessel that courses vertically upwards with a long horizontal segment that courses to screen left, and then 2 arteries that branch off from it that suggestive, of a hepatic vessel, right? A left lobe vessel. There's really not much else this could be. It doesn't go straight up. It's not phrenic. But the issue is that we see a lot of other branching vessels originating from it here proximally. So although the vessel originates here, we see some branching patterns coming off early on, which are concerning given their tortuosity, right? Although these also look very tortuous, given their location, they're most likely liver. This is a little bit too far on the left side in terms of the vessel origin. It originates on the left side of the spine, patient left. And so definitely going to be worried that is gastric supply. And then this is a common sort of gastrohepatic trunk originating from the splenic. How do we determine that that is definitively the case? If you do a lot of the cases, you'll sort of be able to extrapolate from the appearance of the artery what it really supplies. But in 2021, cone beam CT has really made it a lot easier and safer to know for sure. And so we'll do an intraprocedural CT, and we definitively see here that we were right to be concerned that there's a lot of gastric activity. So a lot of activity to the stomach. So you really cannot deliver into that common trunk before the branching to the gastric artery. You also probably shouldn't deliver a dose that even farther into the artery and are only in the hepatic segment. You probably shouldn't deliver a dose that could reflux into the gastric artery. And so that's important to know. We then administer the MAA, and we administered it more proximally to kind of corroborate. This is one of my partner's cases, but it corroborates what we had suspected. There's a lot of activity here in the stomach at the lesser curvature, and that activity actually goes up pretty high into the esophagus here. And so definitely not a place you want to deliver a bunch of radioactive material. This is not always available at different institutions. Not everybody has the capacity to do cross-sectional imaging following the MAA administration. So some people will just get the planar images alone. Those, unfortunately, are what we use for lung shunt fraction, but they're not going to give you that anatomic detail. Certainly, it's possible to use just a planar imaging, but you're really relying on your experience and knowledge of anatomy and anatomic variants to make, because your planar imaging is going to look like this, right? And this is how we derive that lung shunt fraction that we talked about. We measure effectively all of the activity in the liver, and then these are the lungs here. And we get a ratio, which is a very basic ratio of the activity in liver to lung. For most hepatocellular carcinoma patients, you're looking at something around 5, 6, 7%. really large tumors and metastatic disease, you're looking at something that is can be quite a bit higher. So when we're ordering the dose, we need to know what the liver function is. How large are the tumors? Are there more than one? Is it one? And how many vessels are supplying the tumors? And then we have to pick the Sirtex or TheraSphere resident class. In deciding which one to use, we really need to know if there's a chance that we could reflux, because remember, Sirtex will reflux, TheraSphere really does not. That having been said, for really large lesions, we know that we are going to have problems with covering the entirety of the tumor and getting a homogeneous distribution, sometimes with TheraSphere, if a lesion is really, really large, like 5, 6, 7, 8 centimeters and above. Really are thinking, do I need to use multiple doses of TheraSphere, or should I use Sirtex instead? And then you have to play around with the numbers. And this is a little bit beyond the scope of this talk, because we have a lot to cover. And I really will tell you that we did a lot of Y90 fellowship, a ton of Y90 fellowship. I did not actually understand dosimetry. So if you end up doing this procedure at any point in time, there are going to be a lot of resources, and it's okay to not get this immediately, because this is definitely something that's learned with experience, and later on down after you have the basics in terms of the procedure. There's different ways to do dosimetry. And just to make this very simple, the BSA method was traditionally used with Sirtex. It relies on body surface area to estimate how much liver tissue there is. And then just based on that and how much of that liver is full of tumor, you get a dose, okay, for the right or the left lobe. The MERD model, which is the medical internal radiation dose, is something that we use very, very, very commonly. BSA, we don't really use anymore for the most part. The MERD will use the actual liver volume and then the dose that you want to the specific piece of tissue in the liver. It doesn't really calculate how much is going to get to tumor, how much is going to get to normal liver. You can extrapolate those numbers just quickly in your mind with experience. But the partition model is the more sophisticated way to do it, where you can actually calculate, well, how much of the tumor, how much more is the tumor uptaking than the background liver. And based on that ratio, you could say, well, it's not taking up very much, I need more of a dose, or it's taking up a lot, I can decrease the dose that I'm gonna get, because it's a lot hotter on the MAA, on the mapping scan, than the background liver. But the partition model is more convoluted. There's more factors that you have to take into account. It's definitely what people use a lot for research purposes. But really what we're looking at using nowadays is MERD and partition in our practice, and everybody's different. And then after you've gotten your dose, you really can still pick on how many particles you get, even within a certain type of bead, Sirtex or TheraSphere. You can choose to have more or less particles. So it can get as elaborate as you want it to get. On delivery day, which usually happens 1 to 4 weeks after mapping, you really do the same exact procedure, but you deliver Y90 in lieu of MAA. I will say that people have done, and we've also done same-day mapping and treatment, which can definitively be done successfully and is nice for the patient because they only make one trip. The downside is that you really have to get a good handle on your dose, because you have to estimate how much of a dose you're going to need based on how the tumor looks, where the tumor is, what type of tumor it is, if it looks like there's any shunting on your cross-sectional imaging. And so you have to effectively guesstimate what kind of dose you're going to need. And that requires some experience. The actual delivery of the resin and the glass are on the left and right. These, I was trying to find some more action-packed videos, but unfortunately, injecting syringes can only be, so exciting. But on the right, you see that you have one kind of delivery syringe for your glass, for your TheraSphere, with a little overflow valve where the saline drips if you're injecting it too fast. So it really doesn't let reflux. Whereas on the Certec, the resin side on the left, you see that the mechanism had involved two manifolds of syringes, one to agitate the solution, agitate the beads inside the vial, and then subsequently you turn the knob and you switch to the other syringe, which will actually push it upwards into the tubing in small aliquots. You do little pumps, and then you switch it back to agitate again, and then you flush with dextrose in between, because you cannot deliver it all at once because it will clog up the catheter because there's so many particles. So you have to do small aliquots, switching between the D5 flush and then actually a contrast syringe to identify if you have stasis or not, so you don't inject inadvertently in a reflux a ton of particles, because remember, they're very embolic, the Certec. Whereas TheraSphere, you basically finish the syringe, then you do another 2 flushes, and then you're done. So it takes about 5 minutes. This will take anywhere from 10 to 30 minutes to do. So very, very different delivery apparatus, which we'll talk about might be changing in the future. For our case that we were looking at with the young lady with the left lobe tumor, this is our delivery day, and we got the catheter farther in only to target the liver vessels. And what we did is we elected to use TheraSphere rather than Certec. And so you can see here that although there's a halo kind of around the left lobe where we deliver the dose, there's no discrete gastric activity. This overlap is just a registration issue. So there's nothing actually outside, and we don't see any in the esophagus either. There's nothing outside of that left lobe, because we knew we needed to get the catheter really far in into the left lobe. We needed to isolate that hepatic supply, not get any gastric supply. And we knew that if we picked Certec, we would reflux. Now we could have still used Certec with a balloon occlusion catheter, but in this case, it was decided to just use TheraSphere, and this is one of my partner's cases where TheraSphere was utilized for that purpose. And that highlights the importance of why we do the mapping. We would not have had any of that information had we attempted the delivery just outright. And we may have had Certec. It may have been too hot of a dose, too big of a dose, too many particles to avoid reflux into the gastric. Nowadays, we have a lot of tricks and things we can do to work around that, but previously we really didn't. Day of medications really relate to hydration, an antibiotic, which is given IV, single dose, and then antiemetic medication Benadryl or antihistamine, and then a steroid. The steroid, I will tell you, is plus or minus, and this goes for TACE and ablation as well. The steroid make the patient feel fantastic, but you just need to make sure that they're not diabetic, or else they can have pretty substantial issues. And if you do a lot of these cases, there are opportunities to miss that fact, and people can have pretty adverse effect regarding their blood sugar. So just have to be a little careful with what you give. We always send people out on an antiemetic, stool softener, about a week of antibiotics, and this can be ciprofloxacin flagyl. This could be just levofloxacin. If you look online, there's a lot of different permutations that people use for treatment, and then a pain medication, and then pantoprazole, which is a proton pump inhibitor for gastric acid secretion, which is sort of a historic remnant because people would oftentimes have some particle reflux into the gastrics, and that's why this is in there. But there's some people that believe we should still be doing it. They think that it actually has some effect on how well the patients feel for whatever reason. But that's definitely not, I don't think, data driven. And then we have post-procedural imaging that we will do. Any questions so far?
So far, so good.
Okay.
Yeah,
right.
Good stuff.
All right.
Good shape.
Go for stuff. Okay, very good. So post-procedural imaging is going to be our confirmatory SPECT CT or planar imaging, like we talked about. That's done after the procedure. I know some people will not get any imaging after these procedures. I think that's probably the minority, but that is something that is a practice pattern. Obviously, if you don't have access to the nuclear imaging, then you don't have access to it. It's a moot point. But I will say that the benefit for the provider in actually getting this immediate post-procedure imaging is you have an immediate feedback as to what happened in the case. You'll know immediately, did you get the tumor? Did you get coverage? Is there reflux? Was there more activity that you reflux that you didn't see on your angiography, but subsequently shows up on here? It's very nice. What is your distribution? Did you if you're treating a large lesion, did it all go into one side of the lesion because you weren't paying attention to flow dynamics, or you didn't have enough of a dose, you didn't have enough particles? So it can tell you all of those things, or give you some idea of all of those things immediately, so you can tailor how you do this procedure. And I think it's actually very valuable. Now, when do you do follow-up cross-sectional imaging? And this is kind of a very important point for Y90 in particular. This doesn't really apply to TACE ablation. By the way, those pre-meds that we discussed on the last slide, sorry, I meant to tell you guys, you can use those for chemoembolization as well. Where I trained, it was really done ubiquitously. You can use it for chemoembolization, you can use it for ablation even, any liver local regional therapies. Anyway, so the cross-sectional imaging, when do you do it? So this was a scan, an MRI that was obtained after this segmentectomy. And you can see here that we really have an area of residual enhancement or heterogeneous enhancement in this treatment zone. And so you would say that, well, I'm not sure, but it looks like maybe there's some viable tumor there, right? It's in the same kind of general distribution as the prior treated lesion. Well, as it turns out, there actually on subsequent MRIs was absolutely no enhancement there. And the reason for this is one was obtained at 4 weeks and the other one was obtained later. And doing an MRI or a CT or any cross-sectional imaging before 6 to 8 weeks after Y90 delivery will result in you seeing all sorts of enhancement that is an inflammatory response to the treatment. So you cannot do cross-sectional imaging earlier than 6 to 8 weeks for Y90. This is for Y90. This doesn't count for ablation. This doesn't count for chemoembolization, bland embolization. Not a thing for any of this. It's specific to Y90 because of that inflammatory effect from the radiation. So that's a very key point. And then we'll do repeat surveillance about every 3 to 6 months, depending on the patient. So how do you select these patients? We use LIRADS to diagnose liver tumors. And this is kind of an overwhelming slide, but the LIRADS you can find online. And it is only to be used in people with known cirrhotic liver disease or who have had diagnosed HCC or hepatitis. You can't use it if they're not cirrhotic. So very important to remember that. The system goes basically from 1 to 5, 5 being a definite hepatocellular carcinoma, 1 being benign, definitively benign, 2 being probably benign, 3 being intermediate probability of malignancy, 4 probably HCC, but doesn't meet all of the image characteristics, which are really related to arterial enhancement, the size of the lesion, and then ancillary features like a capsule, washout, threshold growth. In this case, you have a lesion that is 4.8 centimeters in the left lobe. It enhances on arterial phase. There is washout, it looks like, on the venous delay. And we know it's 4.8 centimeters. And so it is over 20 millimeters. It has arterial phase hyperenhancement, which we know makes it LR5, because it also has that washout that we talked about, and then that enhancing capsule in this case, right? So it has the 2 ancillary features. In this case, we have a lesion that is about 1.5 or so centimeters that has questionable arterial enhancement, really not very impressive, but does have some delayed washout and a pseudo capsule, we'll say, possibly from this. But given its size and the lack of real definitive arterial phase hyperenhancement, we're going to call it a 4. Just some examples. So what do you do once you have a LIRADS? Well, just to keep it simple, LIRADS 1 to 3, since it's definitively too intermediate, worry. Really, you're just going to follow it. LIRADS 4, if you look on the AASLD algorithm, the American Association for Study of the Liver Disease, they recommend possible biopsy in select cases, or surveillance imaging, or multidisciplinary discussion for treatment. And then LIRADS 5, it's confirmed HCC generally. We have to address this in some way. LIRADS M, which you should know about, is malignancy that looks not like HCC. So maybe secondary malignancy from metastatic disease. In practicality, the biopsy is something we don't do very frequently, with the exception of patients who need a liver transplant, who need the points for HCC. LIRADS 1 to 3, we really just watch them. Our practice pattern for LIRADS 4 is generally not to treat them, but occasionally we'll do a biopsy because those lesions don't technically meet criteria for HCC, and so people can't get points for their transplant list. And occasionally we'll treat these, but it's really a multidisciplinary discussion, usually in patients that really don't have any other option, and we know that their disease keeps progressing, coming back. LIRADS 5, we generally will consider treatment. LIRADS M, if you're worried it's not HCC, then you should be worried. So biopsy. The staging system that you guys will run into most commonly, besides the Hong Kong liver classification, is BCLC. And this staging system really can tell you, or give you some idea of how bad the patient's disease is, how functional is the patient, what should you do to address their disease when taking into account how functional they are. And so you see here that your categories are from 0, A, B, C, D, and these depend on how many lesions we're looking at, the child score, and the performance status. Now, just a reminder, the child score is a function of the presence or absence of ascites encephalopathy, what the bilirubin albumin is, what the PT is, INR is. And so class C really has a much different survival than class A. So liver function matters for these patients. Performance status, as you guys will see, with 0 being fully active, fully functional patient, doesn't really need help, to 4 being completely disabled, really, they don't take care of themselves, they're confined to a bed. Is there a point in treating somebody who's grade 4? That's really, why that's in here. You can see that for very early stage, we're looking at usually a solitary lesion that's under 2 centimeters with a very good liver function, a great performance status, that they do everything by themselves. And then we decide if they're a transplant candidate first and foremost. And generally we are going to see if they are a candidate for surgical resection or ablation at the outset. Realize that this BCLC criteria has been in effect for decades, and so it's really not up to date. You'll see that Y90 is not even in here, and that is just a function of the available literature and actually just getting it in the guidelines. It is definitively used basically throughout stage 0 to C, as we'll discuss, but the guidelines are just not up to date enough. Early stage A, is when you're going to have single lesion or less than under 3 centimeters in patients that have good or intermediate liver function and a good performance status. Stage B, multinodular or large lesions. And you see that this is very gray area, right? They're not giving you sizes, really. They're not giving you there's a lot of room in the BCLC for kind of interpretation when you get in this area right here. But we know that stage C is going to be portal vein thrombus or disease outside the liver, which really changes things pretty substantially. And then intermediate or good liver function, and then not so great performance status. And in those patients, we start to think about using chemotherapeutic agents, although local regional therapy is still done. Terminal stage, best supportive care, right? These patients have very short life expectancy, really palliative, or not even palliative, just supportive care is going to be best for them. And you can see that there's a pretty substantial difference in mortality and life expectancy between those categories. We're looking in this area for local regional therapy, as we mentioned before. And it really depends on the tumor size and number liver function, patient function, and the availability of treatment options, and what your colleagues' knowledge about local regional therapies are. Generally, we try to get everybody to transplantation if they can get to it. Resection is a good option, has good outcomes, except it's not really performed that often because patients generally are too sick. They have portal hypertension. They're not great surgical candidates. So although a segment of patients will be candidates in that 0 group, it's really not that common to see that. And then we have all our local regional therapies here: ablation, embolization with bland particles, with chemo, Y90, and then we have external beam radiation proton therapy, and then systemic therapy, right? The data supports BCLC 0 or A patients getting resection, ablation, or radiation segmentectomy. And they're really similar survival outcomes for those modalities. We like to think that we like to espouse that, you know, there is less procedural related morbidity and mortality with local regional therapies than resection. And really the recurrence rate between ablation and Y90 radiation segmentectomy is very, very close to surgery. It's very similar. When you get to the BCLB group, you can pick anything, and that really depends more on technical capabilities, where the tumor is, how big it is. Generally, if it's quite large, as we'll discuss, we're going to shy away from ablation and either think about combining ablation with an embolization procedure or getting Y90. BCLC-C, systemic therapy really needs to be considered in these patients, but there are patients for which Y90 can actually improve their quality of life, because we know that systemic therapy has a lot of side effects and isn't that effective. And these are kind of the practical points. There's papers that we've kind of utilized to reach these conclusions, and practice patterns differ around different areas, and at least in the States. But generally, a lot of the papers demonstrate that for larger lesions, you're going to get a better response with Y90, particularly if you do radiation segmentectomy type approach. And if you're not doing that, if you don't have access to that, you need to think about combining modalities, because it's quite technically challenging to get great margins with ablation on, you know, a 5-6 centimeter tumor. It's just technically difficult. It requires a lot of probes. It requires a lot of intraprocedural imaging. And it's challenging even if you're good at ablation. Portal vein thrombus, we know that Y90 excels there. It can really retract a lot of that portal thrombus, and we have had some pretty impressive results with it. But there is a caveat, which we'll get to later. TACE also, depending on how you do it, can be very effective for portal vein thrombus. Hepatic function constraints are generally narrower in Y90 than for TACE, but that really only applies to lobar treatments. For segmentectomy, subsegmentectomy, the numbers don't matter as much, but for the lobar treatments, really the numbers that we're looking at are something like this in terms of albumin and bili. That having been said, you need to make sure that these numbers are not in a downward spiral for the patient, because that is going to shy you away from potentially decompensating them with a local regional therapy, especially a lobar one. They can't have any new onset ascites, new onset fatigue. You know, that's going to be concerning that they are decompensating actively, even if these numbers don't look as horrible as they could look yet. And remember that albumin is going to be more of an early marker than potentially the bili. And so if the albumin starts to drop substantially and the bili still hasn't dropped yet, that patient may still not be doing so hot. In terms of clinical trials for Y90, and I'm going to move past these very quickly to get some of the questions done. But in terms of clinical trials, in 2011, one of the landmark papers found that there is improved outcomes for patients that were getting Y90 that were BCLC-C and B. There were survival benefits across all stages of the BCLC. And in subsequent studies, when we compare Y90 to TACE, really we see a big difference in time to progression of Y90, 26 months versus 6 months with the TACE. And that didn't translate into a huge difference with overall survival, median overall survival, but there was still definite better local control with the Y90 without really significant adverse events and toxicity. The trials subsequent to those landmark papers really showed that TARE is more well tolerated with regards to post-procedural pain, but there is a little bit more subjective fatigue compared to TACE. But TACE, when you do it, depending on how you do it, people can get pretty sick pretty quickly. And sorry that there's a question in the chat, which is a good question. Is TACE or just blind embolization obsolete, where Y90 is easily available? Or is it used in some cases? It's definitely used in some cases. We tend to not use blind embolization, I'll tell you, in the States, because for a variety of reasons that are maybe not related to its efficacy, but also because we really only have 1 or 2 or 3 papers that say that it's as effective as TACE. And those are controversial, but TACE, certainly we will still do in patients that have numerous lesions. But that bilirubin maybe is 3, maybe it's 3.5, but it's hovering around 3.5, it's hovering around 3, it hasn't dropped down. The patient's just kind of slowly growing 4, 5, 6 lesions. You don't want to do a lobar treatment for them with a bili that high generally. So we will do a DEB TACE oftentimes. Again, if you don't have Y90 or in certain cases, TACE ablation is also a great option. So we will do TACE and combine it with ablation for lesions that are over 4 centimeters. But good question. RADSEG versus TACE combined with microwave ablation. This is a study that was done at Mount Sinai, and they found that complete response was identical, really, between the 2 modalities. So this is TACE plus ablation versus Y90 for lesions that were less than 3 centimeters. And they matched these patients, and time to progression was very similar between the 2. Subsequent trials have shown, done at Emory as well, have shown very similar results when compared with ablation. Our particular study showed a slight benefit for radiation segmentectomy, which I think can be related to a lot of things, but generally, I think that some ablations are actually more challenging to do in some circumstances. So, certainly the rate of residual recurrent disease is can be higher with microwave, depending on how you do it. It's in some ways less forgiving, but we really didn't see a huge difference that was clinically significant in terms of other factors. But patient selection, again, we'll go back to this slide. And this is a good case example. It's a 55-year-old female with hep C and 8.5 centimeter right lobe lesion, which we have here. And that lesion is pretty much solitary at the current time. I think she had a liver cyst adjacent to it right there. So we brought her in for a mapping, and it's pretty impressive tumoral enhancement there and vascularity, a lot of neovascularity involving multiple branches of the right lobe. And what we ended up doing for her is we elected to proceed with the mapping. We did the MAA injection, which we'll see in a second, which shows us that there's a lot of absorption of the MAA. There's some photopenic areas centrally, secondary to tumor necrosis, and then we see another little friend down there that we didn't see on the initial MRI, but that was a little bit concerning. And we do see good relative uptake compared to the remaining liver parenchyma during delivery. Saw very similar distribution, not identical, but we have a lot of peripheral enhancement. We ended up using TheraSphere 2-week dose for this, which is slightly more beads than a single-week dose TheraSphere. Certainly you can do Sirtec as well in this case. I think you can do either definitively. We did Thera to start with, and you can see on the post imaging MRI about a month or so, 2 months after that. Actually, it wouldn't have been a month because we don't generally do that, but it's I think this one was 2 or 3 months after. This is a subtraction image, and there's still some residual arterial enhancement. You can see that the lesion has decreased in size pretty substantially and has devascularized in parts of it, especially inferiorly compared to how large it was before. We don't really see that satellite well anymore that we were a little bit worried about. That's here. It's really not arterially enhancing. That's a little cyst over there. And so we elected to proceed with a second treatment. You can see that we've coiled the GDA in the interim because in this case, we decided to deliver Sirtec. And the Sirtec delivery was, I think, appropriate in this case. Given the size of the lesion, you really need a lot more particles to go ahead and get a successful result. You can see a very nice distribution, with the exception of that inferior margin, which I think was necrotic based on the MRI imaging. And on our post-delivery scan, we see mostly activity within the tumor, and then another 2-3 months later, we have complete destruction of the tumor. We have some significant atrophy of that right lobe. There's really not a lot of right lobe left, and there's hypertrophy of the left lobe. But this patient actually ended up doing great and got a liver 2 years after her first therapy. So she was bridged to transplantation with an 8.5 centimeter tumor. Are you guys okay on time, or should I just jump to the cases?
We're okay.
Okay. So the data for metastatic disease is going to be less favorable on the whole than for HCC. The most commonly treated liver secondary lesion is going to be colorectal cancer. And that has been studied since the early 2000s, 2010s. Originally, we thought that adding Y90 to a chemo regimen for metastatic colorectal would affect time to progression, and we did have a paper showed some benefit with regards to that. Unfortunately, although there was substantial growth in the use of Zyrtec for metastatic colorectal in the 2010s, subsequent data with large international global trials showed that actually, unfortunately, although you do get some a radiographic response, unfortunately, progression-free survival doesn't really change when you add Y90 resin specifically to chemo regimens, FOLFOX in particular. And there's really no increase in median overall survival when added to first-line chemo, despite the fact that people tend to progress less in some studies. So there's a thought that maybe they, are progressing outside the liver, and that's a result of that. But unfortunately, these trials were they were quite negative for the use of Y90 in first-line therapy for metastatic colorectal cancer. So that's first line. So generally not done much in the United States anymore as a result. And we are looking at if it can be used for second line therapy in people who have failed their first line, or to consolidate their first line treatment. And the EPIC trial, I think, just came out maybe a month ago using glass. It does show that there is a slight benefit in progression-free survival for Y90. It is not the most impressive number that you will ever read. It's about half a year. So we are going to have to wait and see how that plays out. But not negative, not a negative trial. The remaining metastatic MET papers and the data are very complicated. We're not going to get into it today, but the gist is that the evidence is mixed for use of Y90 in cholangio, neuroendocrine tumor, breast mets, other more rare mets. You can certainly always use it, particularly if there is a single metastatic focus in the liver. You're trying to get local control of that. You're going to almost certainly destroy that lesion. The question is, what happens after that? Are you changing their survival? Are you affecting liver function at all? And that's the real question. And it comes down to the disease process and patient characteristics. We have some data from Emory that breast metastasis treatment may show promise if it's done early. We do have a paper from Emory that shows that if you do radioembolization within 6 months of the metastases diagnosis for breast cancer patients, it is a positive predictor of survival with improvement in median overall survival of about a year. But that's still being fleshed out. Future directions for Y90, catheter technology is advancing pretty substantially. We have balloon catheters, we have anti-reflux catheters, we have catheters that can either block reflux or change the distribution of particles. I can tell you that they're much more effective for blocking reflux than for actually altering the flow distally. Just from my experience with them, they're much more effective for that purposes than like prostates. Little different arterial bed in the liver though. So dosimetry software has gotten more sophisticated to allow for people to get more creative with their dosimetry. I don't think starting out that it's critical. I think it's something you certainly can work on, and they're certainly very important for research purposes, but not the most critical thing. That having been said, the delivery system is relatively cumbersome currently still. Tubing everywhere. There's needles sticking into random things in the vial. It's a lot of manual movement, particularly with Zyrtec. So they've really changed their delivery apparatus with making a new box where you really don't worry about reflux nearly as much. More dosing options have come out in the last year and a half, 2 years. Radiodense beads are in the process of being made, because remember, you're not really fluoroing when you deliver, you're not fluoring at all when you deliver Therasphere. And Certec, you're only fluoroing intermittently to look at contrast that you're injecting between injections of the bead, because the bead is not radiodense. Neither of these are radiodense, so you don't see them. In the case of Certec, that contrast that you're injecting intermittently is to give you a surrogate for, are the beads embolic or not yet? Is there reflux yet, or is there a lot of reflux? Do we need to stop? That's what you're doing with that, but you're not seeing the beads. But this is kind of coming down the pipeline. Different agents are studied in terms of radioactive delivery agents. There's holmium in particular is used in Europe. It hasn't caught on to my knowledge in the United States, but it's out there. And now there's a lot of interest in using Y90 for glioblastomas, and that is currently a work in progress, as well as possibly for prostate cancer. Very early works in progress, but they are something to know about. So, takeaway: patient groups most likely to benefit from Y90. Early stage or very early stage HCC who don't have candidacy for ablation or surgery. BCLC-B patients or select C patients are great candidates. Large tumors or patients with portal vein tumor thrombus, and then certain patients with liver metastases. Remember, the side effect profile is favorable compared to chemoembolization. There's multiple ways to use Y90. They're not equivalent. They're very different with regards to what they do to the surrounding liver, and segmentectomy, subsegmentectomy are much more forgiving, and generally, if you can do that, that's what we tend to prefer. There's different approaches that require, different dosing and particle numbers, depending on if you're doing lobar, segmentectomy, subsegmentectomy, and there is a learning curve to all of this, which we all go through. And it is relatively resource intensive, unfortunately, at the current moment. Some questions, some takeaway questions. So which HCC patient groups are most likely to benefit from Y90? We talked about this, but then I'm going to throw in there something that's a little bit of a curveball for you guys. And it's kind of a little bit of a trivia slash kind of institutional experience from my discussions with other people at other large centers. We know that 1 centimeter solitary HCC is probably not necessarily what you need to Y90. We talked about large HCC. Do you guys know anything about the difference between segmental portal vein thrombosis and main portal vein thrombosis, tumor thrombus? Both of those should say tumor thrombus. Sorry, not to confuse. But there is a difference. There's a difference in terms of how treatable it is, and how people respond. And what we see, and obviously E is patients with really poor functionality and with segmental kind of peripheral portal vein tumor thrombus can actually do fairly well, depending on how extensive it is and how quick you are to get them Y90. But main portal vein tumor thrombus is by the time they've progressed into the main portal vein, it is very difficult to do anything about that. It is really not easy to control at all, and their survival is usually something on the order of 3 to 6 months, and it is we've treated these patients before. We've tried to get the Y90 directly into the tumor thrombus. It's very challenging. There's often a lot of other supplies to the thrombus, and it is not usually successful. So not the best candidates. And which statements are true regarding the two most commonly utilized Y90 products? So remember, one of them has more particles and the other one's hotter.
There's someone who responded B.
Yes, I saw the B. Remember, we talk about Sirtex having a lot of particles, a lot more particles. So it's actually A and C. So the TheraSphere, the glass, has fewer particles, but it's also hot. It's hotter. So that's how it accounts for having fewer particles. Whereas the Sirtex has many more particles, but it is per particle does not have much as much loaded radiation. And this is, I know this, it's hard to keep them straight early on. Took me a while too. We talked about the generally accepted post-Y90 cross-sectional imaging interval. You really don't want to scan before
6 to 8 weeks.
Yep, you got it. 6 to 8 weeks. All right. So just to push the dosimetry thing a little bit, I'm going to explain to you what these are. So TheraSphere, we said, is the not as embolic product and with a lot more radiation. We have a 1.5 centimeter HCC here. Which product is most appropriate for this relatively small HCC? F is would not treat with local regional therapy. E is microwave ablation. A is 1 week TheraSphere. B is 2 week dosing. 2 week dosing is basically letting the beads decay for longer, and so you actually order more beads to get the dose you want. And so it has more particles than the 1 week. Conversely, just to make things complicated, but if you can just remember this, then you'll remember the difference between the two. It's the opposite for Sirtex. So the day pre-cal for Sirtex, the higher it is, the fewer the particles, because they'll basically pre-calibrate the dose earlier and then let it decay, and you can actually get fewer particles. There's still more in Sirtex than a TheraSphere does, but the 3-day particles will have a multiple. It depends on which one you order, maybe 5, 6, 7, 8 times, something like that, the number of particles as a TheraDose still. But the 1 day pre-cal will have like 10 times, 15 times, a lot more particles than either TheraDose. And so for this very small isolated tumor, are you going to want smaller number of particles, or a huge number of particles like a 1 day pre-cal?
1 day.
1 day. Yep. I would say 1 day, and you can, or 1 week rather. But just know that there's options. So there are different options. And not to confuse you, but the 1 week and 2 weeks, remember I mentioned this a few times, neither one of them will give you stasis. And so you can use a 2 week I think a 1 week would probably be easy. That's what I would default to for this situation. But realize you can also use Certec, but you don't want to pick the one with a ton of beads. And this is a perfect ablation candidate as well. And this is our subsegmentectomy patient, which on subsequent imaging, 2-3 months after delivery has a little nice hole where the tumor used to be. And we did do 1 week Thera for that. And what about this? This is we'll say it's about 3.5 centimeter, relatively peripheral HCC. We'll say that let's say that the labs are great for all of these patients. They're going to be Child's A. Billy's going to be something around 1 to 1.5. Albumin's, effectively normal. Let's say, how many particles are you going to want for this? Can you do anything else for it? Would you not treat this? Would you tell them systemic therapy or best supportive care? Would you offer them TACE plus microwave ablation? Would you do microwave ablation alone? We said it's 3.5, maybe pushing 4 centimeters for this lesion. Would you use a 1 week dose of Thera? Very small particle number. Would you try to up the particle number a little bit, still use Thera? Would you use Certex? 1 day pre-cal, which is a ton of beads, which we usually use for lobar treatment. Can we fit all those beads into this area? Would you use a 2 day pre-cal assuming you got your catheter positioned right next to the tumor, or would you try to use a smaller number? And I know these questions are a little more difficult than. There's multiple answers, basically. So it's a bigger tumor, right? It's 3.5 centimeters, 4 centimeters. So patient, we said the labs are great, performance status is great. So I think probably could argue to treat them. ABCF. Yep. So basically, certainly you can do a 1 week dose. You can do a 2 week dose. I think some people would say you should do the 2 week dose because it's a little on the bigger side for a more homogeneous treatment. I can tell you, I agree with you. I think you can really use either 3.5, 4 centimeters. If you're getting to 5, 6, 7, 8 centimeters, you need to start thinking a 2 week dosing for sure. The 1 day pre-cal, remember, is backwards. So the 1 day has it's got the most number of particles. The 2 day has fewer. You are going to have a hard time sticking all of those particles into this 4 centimeter tumor if you're in the supplying branch or in the supplying segmental branch to that segment. You're going to have a ton of reflux. So the only modification I'd make to your answer is I would probably decrease the particle number a little bit with the 2 day pre-cal. And I definitely agree with you. TACE plus microwave ablation, I think, would be it. But I think you can use a 1 week dose just to clarify. 2 might be preferred. We ended up doing the 2 day pre-cal for this with Certec, and you can see a lot of the staining. It's just retained contrast in here. And we use the anti-reflux, a balloon microcatheter to make sure all the particles got in. And this is day of procedure, cone beam, a non-contrast cone beam CT. Just gives you a sense of all the contrast that's trapped in there because the particles are completely embolic, right? So the particles have trapped the contrast in there. It's not washing out because there's no forward flow. So that's not the Y90, it's contrast, but that's a kind of surrogate marker for where you embolized and where you got stasis. And then post-procedural cross-sectional CT imaging done at about 2 months. Demonstrates devascularization in that area. So that was very nice. 2 days or took. And that is it. All right. Questions? That was a lot of stuff.
Ah, that was incredible presentation. Thank you very much.
You're very welcome. I
Okay.
appreciate it.
Thank you.
Thank you, Dr. Mircea, for your great presentations. I think everybody enjoyed it and have some points to take on and learn.
All right.
Thank you a lot.
You're very welcome. Thank you for having me. And don't hesitate to reach out if there's any questions or anything. And I will hopefully see you guys at some point, or maybe give another lecture or something. So.
Okay.